Good evening, everyone. At the outset, I would like to thank the organizers for giving me this chance to present in a very important session, which is on supportive care for cancer group, and which is often neglected. So, my topic today is radiation-induced dermatitis, which is a very important topic, and how to manage it. Um, so radiation dermatitis, if you see the overall incidence is up to 95% of the patients who receive radiotherapy. It can be grouped into acute erythematous reactions, which is around 80 to 90%. We see this in grade 1 or 2. And when it becomes moist desquamation or grade 3, it is seen around 10 to 15%. So the incidence is higher with an altered fractionation schedule and concurrent chemotherapy or immunotherapy. So radiation dermatitis, moist desquamation or ulceration of the irradiated chest wall or the breast skin, which is grade 3 or 4 toxicity, has been reported 20 to 25% who receive radiotherapy to breast. And in head and neck, the incidences are more, and they experience mild to moderate with starting grade 1 to 2 radiation dermatitis, while about 25% patients experience severe toxicity, which is grade 3. If you look at the cancer specific incidence, the head and neck cancer specific studies have reported grade 3 skin reactions up to 20 to 25% of the patients. And we see this very often in the head and neck radiation. And if you go to gynecological radiotherapy, the incidence is around 10 to 20% only in the randomized trials of endometrial and cervix cancers. But when you come to vulva, because it is exposed, the incidence of radiation dermatitis is higher and it might almost range from 40 to 80%. So grade 3 or 4 skin reactions are less common in cervical and endometrial cancers, around 1% to 5%. However, patients with vulvar cancer have a substantially greater risk of grade 3 or grade 4 reactions, which is ranging around 24 to 53%. Now, how to identify the radiation dermatitis risk factors? So you can group it into patient related or therapy related. So if the age is very high, I mean, as the age is more, they are prone for more radiation dermatitis, and the area of treatment also. If there are, if the obviously if the area treated is more with skin folds and moist areas, the radiation dermatitis is more. The nutritional status, the smoking and alcohol use govern the radiation dermatitis. Comorbidities may increase it. Chronic UV exposure along with radiation might increase, and obesity, of course. When you come to the treatment related things, so the radiation dermatitis is dependent on the type and energy of the radiation and the beam. The higher skin dose is known with electrons and also the older treatment machines like cobalt 50 and cobalt 60 machines, and fractionation dose, total dose also govern radiation dermatitis. If there is a hyperfractionation, 2 fraction per schedule, then you would expect acute dermatitis to happen rather than hypofractionation. The treated volume and the surface area, if it is more, then the radiation dermatitis is more. Using of bolus materials and type of treatment planning. If conventional techniques are used, the radiation skin reaction is more compared to the modern techniques of IMRT. Concurrent chemotherapy and immunotherapy might increase because many of the targeted agents also cause skin reactions like EGFR receptor antagonists, and when they are used with radiation, there is a increased risk in radiation dermatitis. And prior history of surgery also might alleviate the radiation dermatitis. Now, how does radiation dermatitis proceed? We see typical erythema in week 1, which is grade 1, which progresses to dry desquamation or pigmentation in week 2, and it might progress to severe pain, moist desquamation in week 3. And in uncontrolled things, it might go into ulceration, which we term as grade 4. This is about acute. And post radiation in chronic dermatitis, we can see radiation edema, keratosis, dermal necrosis, fibrosis, which is the most commonest, and increased hyperpigmentation and epidermal atrophy and vascular injury, which is also called as telangiectasia, which might be seen after about 6 months up till 5 years based on the intensity of radiation. Very less common, can say less than 1% or even less than that, chances that there might be a progression of this chronic radiodermatitis into a melanoma or a skin cancer, which is very rare over years, probably around 5 to 10 years. So it always starts with erythema, which is a reddened skin that might not be erythematous and feel hot. And the pathogenesis is due to the histamine release. And it typically starts with 20 to 40 gray. And the redness around the treatment field, which intensifies with the treatment, is the definition. And there is a capillary dilatation and RBC extravasation. Now it might progress to dry, flaky skin, which is itching, and it is called dry desquamation, which can cause when the radiation doses are more than 30 gray, and normal cells produced faster than the damaged cells which are removed are the result of this. And it might proceed to grade 3, which is moist desquamation, which is serous drainage, typically around the region of friction. And this happens when the radiation doses are more than 40, and the skin may blister and become moist and edematous, and there might be a exudate, which can cause the patient uneasiness, and there might be a oozing of the exudate, which is the typical of grade 3 reaction. So here, if you see in this picture, there is a very early reaction, which is hyperpigmentation. And B is a moist, dry desquamation, and C is the moist confluent desquamation. So this is grade 1, grade 2, and grade 3 all depicted in this single picture. So diagnosis is very clear. There would be a irradiated field, irradiated volume has to be determined, and there will be a history of radiotherapy along with chemo, surgery, and clinical examination is by inspection and palpation. And very rarely there might be a requirement of histopathological examination. And to just differentiate between a malignancy and the radiation-induced fibrosis, we might also use an MRI, but it's very rare. You can make out the radiation dermatitis with the history, and it is evident. Now, RTOG grading again, this is acute radiation dermatitis where erythema is grade 1, and patchy moist to dry desquamation is grade 2, and confluent moist desquamation is grade 3, and grade 4 is life-threatening consequences with skin necrosis or ulceration with full thickness dermis and bleeding from the inward side. So you can see this again. This is the depiction of grade 1, grade 2, and grade 3. Now, how do you manage the radiation dermatitis? Patients, prevention is always better. So patients are advised to wear loose fitting clothing during radiation. And very importantly, we need to avoid the friction or rubbing of the areas of the treatment field. Many a times when head and neck areas are treated without the knowledge, when the patient sleeps, there might be a friction with the when they are sleeping around and turning around, and we need to be very advise. We need to advise them, and they need to be very careful that this friction is avoided. Cosmetic products, extreme heat or cold or sun exposure should be avoided. In addition, if there is a shaving or a treated of the treated skin, it should never be uh, from you can use an electric razor or a clipper, and it should never be cut with a razor. So how do you prevent it with nutritional supplement? So you can give a beta hydroxymethyl butyrate or arginine or glutamine, which is known to have a decreased effect of radiation induced skin reaction more than grade 2 and in shorter duration of grade 1 also. Topical oil, olive oil or vico turmeric or trolamine emulsion can help in reducing. Lactocalamine, which is the most commonest, are also used in preventing the or reducing the radiation induced reaction. So hygienic option, washing is an option, but we should be very careful that mild soap and lukewarm water is useful, but the patient should be advised not to rub it. It is very meticulously done, and washing is a tricky situation. If you rub, then there might be a skin peel off. So washing is an option, but there has to be a training for it. Corticosteroids is the most commonest for effective thing in radiation dermatitis, and there is a level 1 evidence to it, and it has anti-inflammatory effects and inhibits the surge of radiation into cytokines. So the meta-analysis of Haruna group showed that the topical corticosteroids prevented the incidence of wet desquamation and reduced the mean RD score. So it was very evident, and momentosine was a very important drug. But in our routine practice, we use Lycor, which is 1% hydrocortisone, which is very effective in reducing the grade 3 dermatitis. Very perceived think that these agents work, but they don't work. That is aloe vera or chamomile or ascorbic acid. These all have been used, but they don't work as much as the other agents. Now, some of the very important skincare precautions, our own Talapatra et al. Group came up with this publication, and what are the do's and don'ts. So, again, to emphasize, the clothing should be very loose cotton clothes. Skin has to be kept dry and clean, and we should wash the irritated area with lukewarm water, and use of soft cotton towel and dabbing. You should never rub it. And our skin trauma, use gentle fragrance free balance soap, pH balance soap, and a mild shampoo. You can use a gentle moisturizer to prevent dry skin and pruritus. Adequate nutrition and hydration is very important, and it is very important to discuss with the doctor before applying any creams or ointments, because there will be a thing which radiation oncologist can direct which to apply and which to not. So it is very important to keep him informed. What are the don'ts? Never use tight elastics or collared clothes, which is the most common cause. We tell that when the head and neck radiation is administered, clothes are to be banned, and avoid perfumes, deodorants, and also eyes or heating pads and direct sunlight. And in nutrition, avoid spicy and oily foods. So management, when it is grade 1, you can get away with a topical moisturizer or antibacterial ointments. When it is grade 2 or grade 3, the moisturizers can be combined with antiseptics or anti-inflammatories, and hydrophilic dressings and steroids, which is most commonly used as hydrocortisone or mometasone. In addition, send a swab or microscopy and cultures when it is grade 3, and you might have to give antibiotics or antifungals when it is a infective confluent grade 3 dermatitis, and when it is grade 4, it is treated on case basis, and there might be a very important thing that a dermatologist is involved, and specialized wound care or graft also might be needed in grade 4 in severe cases. So these are the clinical practice guidelines for MASCC skin toxicity group in 2013. So adoption of washing with water with or without mild soap, and allowing the use of antiperspirants is supported by the randomized trials. Use of topical prophylactic corticosteroids. Here they use mometasone, but we are comfortable in using 1% Lycor, that is hydrocortisone. And there is some evidence that silver sulfatizing cream can reduce the dermatitis score. There is insufficient evidence to support, and therefore the panel recommends against the use of these things: trolamine, tropical sucralfate, or hyaluronic acid or ascorbic acid, and even agents like oral zinc or pentoxifine. Now, this is a new thing which has come in the market for avoiding the radiation-induced dermatitis, and it is very new invention, which is film-forming silicone gel extracts, and it helps to reduce the transepidermal water loss. So it keeps the area moisture intact. So it promotes the moist wound healing environment, leading to faster re-epithelialization of the skin post-therapy, and also relief of low-grade cutaneous changes such as dry, itching, flaking, peeling, or irritated skin. So basically here the moisture is retained, and with the moisture environment the healing is better. So it protects the fragile epidermis during the dry desquamation, leading to preservation of the skin integrity and also prevention of excessive sloughing of the outermost layers. It protects the dermal stroma from long-term deterioration during the moist desquamation, leading to optimization of the environment for the reparative process, and also reduces the risk of infection. So what are they composed of? They are composed of polymethyl siloxanes, which is the most widely used silicon-based organic polymer. And there is also siloxanes, which are, as the name suggests, derived from the silicone and are typically used in cosmetics to soften the skin, smooth out imperfections, and also to moisturize an otherwise dry skin. Alkyl methyl silicones, they increase the durability of the film, and it is occlusive nature, prevents the transepidermal water loss. So basically, the water is retained and the moisture is retained, and the environment is itself a moisture forming repair. So it helps in the keeping the moisture intact and thereby repairing skin repair in that environment. Now, there was a randomized study which used this silicone gel, and it was recently published in Green Journal, where they compared the silicone gel with a sorbolene cream, and the outcome was severity of skin toxicity and also related to quality of life, and also pain inventory and itching was measured, and treatment interruptions and adverse events were also measured as the secondary outcomes. And this was given in head and neck cancer who received radiotherapy at least of 50 gray, either in primary or postoperative treatment. So it was a randomized trial, but it was a single blind trial. And you can see that the silicone forming gels have better outcomes compared to sorbolene, and experiencing lone beam toxicity at the end of radiation treatment period compared to the sorbolene arm was around with a 95% confidence interval of p-value is around 0.002. So it is a very good invention which preserves the TEFL and helps in reducing the skin toxicity. So conclusion to the talk is that there is no gold standard therapy for this particular toxicity. As far as the toxicity assessment, many scales are used. The commonest used is the RTOG or the URTC, Lent or SOMA scale. Washing with mild soap and water, topical corticosteroids, and silver nylon dressings have proved effective in managing the radiation dermatitis. Several other agents, including the hyaluronic acid, EGF, or even GM-CSF and statins, are used, but may potentially be useful in managing the acute RD, as respective studies have demonstrated the positive results. And the new thing in the box is the silicone gel, which can be applied following the initial dose of radiation for the duration of radiation therapy until full skin recovery, which is shown to help in reducing the radiation dermatitis. Thanks. Thank you.